Today I was talking about really 3 case studies of work that we've done to evaluate community-based services and to look at whether or not they were impacting on levels of emergency hospital admission in the ways that they thought they were. So one was an example where we'd used big data sets, existing data sets, to support a prospective clinical trial, a cluster randomized trial of a technology called telehealth, which is about supporting people with chronic health conditions, supporting them in their own home. And what we were looking at there is whether or not this technology led to a reduction in emergency hospital activity. Actually, what we found was there was a reduction, but in some ways the results were ambiguous. And it also demonstrates some of the problems with prospective trials in that they can take quite a long time for the results to emerge. And in areas such as health technology, where the pace of change is really quite fast, it's difficult to generate evidence in the timescales that's required to inform decisions. I think there's 2 issues that we've found in trying to make better use of the existing information. One is about permissions, the information governance, and people understanding what you're doing and how you're handling the data to make sure it's secure. And that can actually often take quite a long time to get agreements from all the relevant actors that what you're doing is valid and valuable, and that you are looking after the data that you do hold, even though you're conforming to all the requirements of information governance. I think the second area is about developing the analytical capability within health services to use quite complex evidence in decision making. So it's more than just the data and it's more than the statistics, it's about the people to interpret and communicate those, and particularly to senior managers and policymakers, so that you actually do influence the decisions that they make. One of the things that Nuffield tries to do is to act as a trusted place where people can debate these issues. So in the past we've had discussions around information governance, we've produced reports on them, but we've also brought people together from within the health service to talk about the challenges that they face and to share the experiences that they have on those issues. I think we're also interested, we're quite well connected in policy terms as well, so in communicating some of the messages about better ways to use information and the importance of information in decision making in health services. One of the questions that came up in my session was about how we can develop methodologies for research that are actually quicker and more responsive, and for example to do forms of randomization that are closely linked in with the everyday delivery of care. So that's an area for me that I think that is taking off, and I hope will develop over the next 12 months, next 24 months, to become a key area in future conferences. I think some of the pace of change in relation to the Internet of Things, the way that the technology of devices and data collection are changing, offers a lot of possibilities as well. I think some of those are red herrings as well, and there are some dangers in being too preoccupied with data collection for data collection's sake. But I think there's some really interesting possibilities about how we can have new streams of data and data that's more relevant to, say, the delivery of healthcare services than some of the existing ones. So in particular, I'm thinking about how do we combine patients reporting of their experience or of their health status in a timely and efficient way with some of the information that I typically use about activity and cost. And I think we really need to crack that on a large scale and across a range of different patient groups. The issue for me is about how do we get tools that are translational, that go from the laboratory, from the academic institution to the shop floor of healthcare delivery. So it's those issues about embedding change in the right way within everyday service delivery that I think are really important. So how do we get those tools onto people's desks and get them valued by those users? That seems to me the key issue. We've done a lot of work on predictive risk modelling and whether or not predictive risk modelling can reduce the probability of a future health crisis that leads to emergency admission. And we know we can build models that are statistically valid, that have got predictive qualities, But the key issue is how then do you use that in practice? How do you fit that into the day-to-day work of a nurse or a GP in ways that informs their decision making, that leads to the types of decisions and the types of changes that produce better outcomes? And that's the really hard part. I think the algorithms really need the humans.